Okay, so we'll get started and I'll just start again. My name's Josiukas. I'm a psychiatrist here in Collingwood, and I'm going to give you a thumbnail sketch about who I am, so hopefully giving myself some credibility. So I'm originally from this area, and I started practicing in Collingwood as a psychiatrist in 1988. So I've been with the outpatient mental health clinic at the Collingwood General and Marine Hospital since that time forward. So I guess I am truly a rural psychiatrist, one of a dying breed. The average age of a rural psychiatrist is well over age 55 these days, and the great concern in our communities is that when the likes of me retire, that there's not going to be a newbie coming in to take our place. We have other itinerant psychiatrists at our clinic, but they are all as old as I am, if not older. So I think that this day is really important, not only from a pandemic lockdown adaptation point of view, but also adapting as some of our resources age and retire. So thank you all for coming. It's really wonderful to see such a group of people with a broad range of interests and skills. But as we start, I wish to extend my gratitude to a number of individuals, families, and organizations for making this event and this project possible. Firstly, the Rural Ontario Medical Program, which serves all 5 Ontario medical schools by arranging for placement of medical trainees in most of our rural communities. It's a wonderful program, and I know that the graduates, the people that have the opportunity to transition through the program, acquire skills that they would not get in major metropolitan centers. I would like to thank the Collingwood General Marine Hospital, the local family health organization, all of our guest speakers, and especially the people that are joining us from afar, both virtually and the speakers that are coming from afar. The work that you'll hear about today was sponsored through a grant from the United Way, and the ongoing and overwhelming generosity of the Knowles family. So to them, thank you, thank you, thank you. I don't have any slides, and that's for several reasons. Firstly, I would like you to just focus on what I'm going to say, and if you take home one nugget from my presentation, then it will be time well spent. The other reason is that I have an invisible disability, and I think that that's really a good pun on my visual impairment. So just looking at you, whom I cannot see very clearly, I think it's actually wonderful to be up here speaking and not having to distract myself by slides. I will be speaking for about 20 minutes, and the reason for that is that our average human attention span is 20 minutes, and I think that we need to maximize that. So there are 3 concepts in the title of our presentation: adapting, which you will hear from the following speakers; mental health, which will be the focus of my discussion, and the word community, which will be interwoven throughout everything that we speak about. And to me, the reason I came to work in Collingwood, Muskoka Beach, Stayner, Clearview, the whole catchment area, was the sense of community, and that is the reason that I stayed for so many years. It's that sense of belonging that is so important, and I will circle back to that over and over again because it's our connectivity to each other that is so important in our mental wellness. At the start of the pandemic, some of us, especially those of us who had survived the SARS crisis, became deeply concerned about the effect this situation would have on mental wellness. I thought that if COVID-19 was the earthquake, then mental distress was going to be the tsunami. And in fact, we are still living the tsunami. We predicted a strain on our existing healthcare programs. And then we did not predict that the incipient lockdown would create its own set of problems by people refusing to access care and refusing to come to the hospital emergency room, fearful that they were going to succumb to COVID, and then having their pre-existing horrible life-threatening conditions worsen. We predicted the destabilization of people with established physical and mental illness that were well managed, that they were going to run into trouble. And we did predict the psychic distress that all of us would encounter because of uncertainty and fear and worry about those family members of ours that had disabling conditions. That we were really good at. We predicted that. But we didn't predict or foresee the effect of mass migration into our rural communities. And I feel particularly guilty of that myself, given that I am a child of displaced persons from World War II, that I did not predict that there would be mass migration. So the pandemic, the fear of the virus, the lockdown, and then the migration into our areas placed an extraordinary pressure on our delicate healthcare ecosystem. I think that's so eloquently put, and I will not take credit for that. That was plagiarized from the Rural Ontario Municipal Association document. But let's just think about that. We do have a delicate healthcare ecosystem. And the healthcare ecosystem is not just about healthcare. There has been pressure on our policing, our social services, our water and sewer. And would you believe, pressure on our garbage collection systems? And I'm saying that specifically because Michelle alerted me to that big problem as people have migrated into our areas and now depend on those services. We failed to predict the great economic recession that we are living now, with unattainable housing and the complex impact that the lockdown has had on society's approach to employment. And that is a topic for bigger discussion from minds that are greater than my own. So what is health? The answer is bigger than what we think. Several years ago, I attended a family practice meeting because I am so blessed to be part of the family practice group in Collingwood. And the question was raised, what is the greatest health advancement that changed the world? And the physician group came up with the usual round of suspects: antibiotics, and that was certainly mine because my father was a physician before antibiotics, vaccines, but none of us came up with the real answer. The real answer is sanitation and clean water. We did not consider it because we all take it for granted. But those of us who do home visits on a regular basis, and that includes me, we know that there are people in our rural communities that do not have indoor plumbing, that still rely on outhouses. We know that there are farms where people are working very hard to maintain our food supply, but they do not have the basics for their own survival. We know that farming particularly has been stressed by the pandemic and the lockdown, because many farms survive because people work out of the farm in order to supplement the farming income. That is a reality of our rural communities. So the Government of Canada released a document in June of this year reviewing the social determinants of health. To survive, all of us need an income to purchase the things that will keep us safe. We need a roof that doesn't leak, a source of heat in this weather, and food. In many of our outlying communities outside of Collingwood or Muskoka Beach, people are still using wood stoves to heat their buildings, propane, things that are alien to us that are town dwellers. We also need opportunities to interact with one another, and that is crucial, and that's why I'm so happy to see so many people came out in person today, because it is interaction that keeps us living. And we need meaningful daytime activity, and all of those things were jeopardized by the pandemic and the lockdown. I imagine most of us today work either directly or indirectly with people. And how many of us care providers, whether it be social service workers or healthcare or psychiatry or mental health workers, actually know the specifics of the social determinants of health of the people that sit across from us at the table? Studies have shown that 60 to 80% of people are less than forthright when speaking to their personal physician. That is a mind-boggling statistic, given that we hope that we can at least trust our doctor. Physicians are trained to ask about personal determinants of health, current symptoms, habits, family history. We all know the drill. It's drilled into us. But we are not trained how to ask about social determinants of health. We're not trained, we're embarrassed, we're afraid that we're going to embarrass the person that we're asking about their source of income, about what they had for breakfast. Returning to the pandemic and its costs, and now I use the word costs, not just consequences. The pandemic and the lockdown and the mass migration has been stressful for everyone. Research, Oprah, Dr. Drew, name your talk show host of your favorite talk show host. They have all told us that stress has an impact on our physical health, our problem-solving skills, and our emotional well-being. And that is an added stress I did not consider. We know cold sores pop out, migraines worsen, and blood sugars go wonky when we are stressed. We all know that. Some of us are keenly aware of impaired problem solving when under stress. I remember many years ago going on a house call with Dr. Savage, a local family doctor, to deal with a very difficult situation. The situation deteriorated quite quickly, and it became apparent that we were in need of police assistance, because otherwise Dr. Savage would be using the emergency room himself. Good punctuation. For the life of me, I couldn't remember the address, and I couldn't remember the number to call for the police. The stress was so high that all of my problem-solving capabilities went out the window. Luckily, there was a happy ending to that story. We know that we stopped exercising when exercise would be helpful. We stopped praying when we should be praying the hardest. Data has shown that during the lockdown, people started drinking more, using substances more, smoking more, resorting to all of the bad habits that they had somehow learned to control. Virtual AA was not as good as in-person AA. And, ladies were telling me that they were shopping a lot on Amazon, and that there were costs associated with that habit. The pandemic and the lockdown and the migration has disrupted all of our lives, our scheduled lives. Scheduling is a building block for health. We no longer said, okay, kiddos, time for bed, you have school tomorrow. If we enjoyed physical and mental wellness pre-pandemic, these feelings of good health were seriously shaken. In 2021, the Canadian Mental Health Association published an important document distinguishing, geez, my legs are longer than this hole in the podium, distinguishing between mental health and mental illness. This seems self-evident, but actually it is not, especially since there's been a lot of money funneled into mental health now by government agencies. But it has not been designated as to what goes for mental health well-being and what goes to actually help those with mental illness. Today it's fashionable to speak about mental health. Everyone has physical health and may experience challenges to their physical well-being, and every one of us has mental health, and we may experience challenges to our mental well-being. Our well-being is disrupted if our favorite furry companion dies, or if our paycheck bounces, or if there's a disruption to the family. But not every one of us develops mental illness. Social determinants like food insecurity, unstable housing have a profound impact on those with mental illness. And we just have to look around us and all of the people that are living under tarps right now, or have most of their ODSP check go to pay for a bachelor room at one of the horrible motels in Muskoka Beach, to know that their wellness is impacted and their illness is impacted. So what are the statistics for mental illness? So if we have a catchment area here of 70,000, we should have 700 people with schizophrenia in the community. We should have 700 people with bipolar illness. 4% of the population have anxiety, 5% have depression, 6% have substance use. The actual rates of incidence of mental illness have not gone up during the pandemic and the lockdown, but the incidence of eating disorders has really gone through the roof. I do not have the specific numbers, but pre-pandemic, the incidence of eating disorders was anywhere from 0.3 to 1%, And now if you call Dr. Federici, the eating disorder psychologist in Midland, she is overwhelmed with a number of teenage girls that are presenting with eating disorders. So all of these things are just names for people that do not actually work with people with major mental illness. But I'll give you an idea of people who have mental illness. So, those of us who grew up with the Beach Boys know that Brian Wilson had schizophrenia. And those of us who read history know that the only reason Winston Churchill was able to go for 2 weeks without sleep was because he was in a manic phase of his bipolar illness. We know that Dan Harris, the ABC weekend morning host, has anxiety disorder. He had a panic attack when he said, and I'm giving it to Diane Sawyer. And we know Amy Winehouse had a substance use disorder, and my hero, Jim Morrison, died of a drug overdose. But I'm an old gal, so I'm quoting old people. And the most famous eating disorder person that we know of is Karen Carpenter from the Carpenters. The cancer risk is 1 in 2. The risk of mental illness is 1 in 5. But the Canadian Mental Health Association says that by age 40, 1 in 2 of us will have had an excursion into mental illness. So that's pretty staggering when we think about that. So if we entered the pandemic and locked down unwell with a pre-existing illness, and we could not go to our programs, and we were afraid to go to our family physician, and we could not rely on our support circle, which would include peer support or our social service workers, or our AA meetings, or our church activities, because we were told to hunker down. We were in a bad way. But what if we moved from Brampton or Oshawa or Mississauga with our family, and we had schizophrenia, and we did not have a local family doctor, and we did not have a support circle, and God help us, we did not have access to psychiatry. What did we do? Well, people hunkered down. They followed the government instruction, and we know from some of the statistics that were done for this research project that the number of visits to the family health team dropped substantially. The number that was quoted was 31%. The number of referrals that we were seeing at outpatient mental health dropped by over 7%. And the numbers attending the community health center dropped by over 40%. That's staggering. People were really hunkering down. But they were still in need of services because of all the factors that I've already talked about. So the Mobile Mental Health Response Unit, excuse me, the collaboration between mental health crisis and the local police had an increase of 69% of visits. And Dr. Chisholm, who's going to talk a little bit later, has a better perspective on our emergency room. But typically 20% of emergency room visits are mental distress related. There was one day in the emergency room where 100% of the visits were mental distress. The pandemic, the lockdown, and the migration has affected all of us. Some of us are kinder. Some of us are more irritable. The hospital now is overflowing with security staff because, God forbid, someone gets irritable. The bylaw people are very busy these days because we're not acting in a neighborly fashion. We don't go next door and say, hey, your RV is blocking my vision out of my driveway. We call the bylaw people. The participation rate at local volunteer organizations has plummeted. Last week, one of the optimists that I see said that it was typical for them to have 70 or 80 members, and now they're down to 10, and they can't recruit more members. However, people have become more generous. The women at the Catholic Women's League that collect money for the food bags that they graciously give to our program and to the family health team and to the CMHA. The number of dollars they collect to prepare those food bags are staggering. On the other hand, people are really still not embracing one of the building blocks of mental wellness. They're not participating. So when a local church has a community dinner where we could all go eat and share our life experience with our neighbors, have turned into grab and go sessions. And that's not healthy for any one of us. The other thing that has happened is that the divorce rates are going up. My friend, who is a matrimonial lawyer, has told me that he's never been so busy as he has been since the pandemic started. People have realized that they can't stand their spouse. So, the pandemic and the lockdown has affected mental wellness and those of us that suffer from mental illness. Where do people turn to? Where do people go if they wish to seek help? Well, they go to the emergency room and they are returning to go to see their family doctor. Family medicine has traditionally addressed 80% of mental health and mental illness needs in all communities. But family doctors cannot address these needs without the tools, the interviewing skill tools, without the tools to know which are appropriate resources in the community. It's really worthless to tell a person, well, go call these numbers if you haven't vetted those numbers and know what is available at the end of the telephone call. So today we'll hear about tools that were developed or adapted to address the sequelae of the pandemic. And I'll leave that to the people that will be speaking after me. So as I close my portion of this talk, I would just like to thank some individuals that have played a role in the care that I have provided for the community. I would like to thank several members of the community, although they are now in heaven, like George Sheffer, who used to be the police chief in Collingwood, who early on identified a need for mental wellness. I would like to thank Claire Robertson and Cal Patterson and Walter Borthwick, all of Muskoka Beach, who were incredibly generous with space for the provision of mental health care in Muskoka Beach. But above all else, I would like to thank the individuals that have trusted me with their lives. They've shared their hopes, their dreams, their disappointments and their heartaches with me. And we have built long-standing relationships, and I always have believed that relationships are the building blocks for health. So if I was Bob Hope right now, I would just say thanks, or I would sing thanks for the memories. So I'm open for questions if anyone has questions before we go on to our next speaker. One thing that I did not address, only because it is so deeply painful for me currently, is death by suicide. Last week, there were 3 people that I knew that died by suicide. And in this pandemic, as is often the case with some worldwide disasters, suicide rates remain steady or fall. But as we're easing out of the pandemic, we don't have the data yet, but just by the numbers that I'm seeing coming into the clinic, I suspect that the numbers will be going up. So yes, you have a question.
Hi, and thank you for sharing that with us, because I was going to mention that. I work at a hospice, Simcoe and Barrie, and we are seeing a 300% increase in our traumatic grief support. There is numerous cases of death by suicide, death by drug overdose, death by homicide, horrible accidents. So our community is incredibly impacted by this sadness and this heaviness. And bereavement and being sad is not covered by a mental health illness. So it's difficult to get paid support for being sad. So hospices have really seen an incredible uptake of helping these individuals through their traumatic grief. And unfortunately, we are seeing an incredible uptake in children. They have lost a parent or a sibling to drug overdose or suicide. We have supporting a couple of children that have lost both parents to drug overdose or suicide. So this is going to impact our future of our children. These children need to be supported. And there's currently no paid program to support children through their grief. So hospices are doing this on donor dollars, and it's incredibly impactful to our organizations and our staff, and doing our best to try to reach out. But I just wanted to say hospices are doing what we can, but it is having an incredible impact on our community. Absolutely, a suicide and drug overdose.
I would like to laud all of the work that hospice does, because I think it provides an incredible support to people that are dying and grieving. I think that grief is one of those things that defies easy definition, because the American Psychiatric Association has clearly said that symptoms of grief that last longer than 2 weeks are diagnosable mental illness. And yet I know from personal grief that grief never leaves you. It's an irreparable thing that happens to your soul. And yes, you might be able to function, but grief becomes part of your life. So it is very sad that we do not have the resources to help people deal with grief, especially with the breakdown of our social building blocks, because people have not been going to church, because people have not been going to AA, because people have not been going to the Lions or the Canettes or the Optimus clubs. People have been avoiding their musical groups or whatever they did to interact and to share their life story. They have been following mandates, hunker down. And it's not the same to be seeing someone on a screen as it is to be sitting with someone and holding their hand as they cry.
Are there any other questions? Yep.
I think that many of us know that, oops, there goes my jar. I think that many of us know that psychiatry is a challenge to access because of what you had shared, that so many people are nearing the end of their career as opposed to starting. And I'm just wondering if you have any words of wisdom for how do we attract more psychiatry to our rural communities?
Well, that is a loaded question. For 20 years, Michelle and I have tried to work with the universities to try to encourage learners to come to our rural centers. Waypoint in Penetanguishene has had psychiatrists in training go to their facility. But university settings are very, keep a tight fist on their learners because learners do a lot of the hands-on work. I think that we need to hold on to the people that we still have, make it as feasible for them to continue working as we can. We need to enhance the skills of family doctors to do more. And I don't have any words of wisdom. You know, at our clinic, in our community, South Georgian Bay, we should have 7 full-time psychiatrists. We have less than 2 full-time equivalents. Dr. Bale, who's with us 2 days a week, and he's been with us, I don't know, 5, 6 years. He was telling me last week that he has had 9,000 unique per patient contacts in just that time frame. That man is working very hard. We're trying to do the best we can. I think CAMH has written a document about this shortage, and it's a shortage countrywide. Psychiatry is not a sexy profession, you know. We deal with raw emotion, we deal with cognitive impairment, we deal with people when they're not at their best. It's trench warfare sometimes.
Any other questions? Yeah, Kelly.
I'm sorry about this. I also wanted to just bring to everyone's attention, or possibly your attention. I didn't see it on the agenda today, but in our palliative care world, medical assistance in dying is also very much on the increase. We're seeing more and more referrals, with track 2 being now that you do not need to have a terminal illness. And in the spring, we're going to be talking about mental health illness. And I'm just not sure how this community is going to adapt and respond to the requests for MAID in this very difficult world that we're in with lack of mental health supports. But that's also a pressure point that we're starting to see, is increase in track 2s and a lot of questions around, like, people are calling and waiting. They've called and asked, when can I have MAID? I want to know when this legislation is through. I've attempted suicide 11 times and I can't wait for this legislation to come through. So what does that look like in the spring? I don't know. So that's why I'm here today. I'm looking for how are we going to adapt to that and adapt to our bereavement.
So I will just say something that Dr. John Mahar from the ACT team talked about some time ago, and it was published in the Hamilton Spectator. He said that one of the most important things about mental illness is that we have to instill hope, and that we have to never give up trying to help a person manage their illness. Granted, for these biological illnesses like schizophrenia, bipolar illness, There is no cure. We can only help manage the illness. But it is so important for those of us that work frontline to instill hope and to never give up.
Thank you, Dr. Josiukas. So with that, I think we're going to move on. We appreciate you sharing today. We know that your 30,000 patient encounters in the local community is not lost. We have been able to also have many trainees and learners in family medicine be gifted with your expertise. And we're also really working towards a plan for hope in the midst of hopelessness, which we're unsure of which direction to go. We do know there's not the psychiatry positions that we had hoped there would be, not only dedicated for rural, but they're not dedicated in the country right now. But we do have an opportunity with expansion and family medicine and enhanced training for physicians to support one another and to support the growing field of mental illness, as well as how to support community providers and with mental health care. So thank you for your time today and your kindness and your generosity in your work. It is such a special gift to be able to have for those that have really needed your support and your care. Thank you.